Hi, everyone. Thank you for taking the time to join this Ipsos and LVVC webinar today. Today's webinar will be focusing on the patient perspective, evaluating time and treatment while living with metastatic breast cancer, and focusing on highlights from the quantitative research conducted with patients living with ER-positive, HER2-negative MBC. A white paper with these results is also published on our Ipsos website with the same title, if you'd like to give that a read afterwards. My name is Matt, and I'm with the Ipsos team and help lead this initiative, and I'll be moderating the Q&A session held at the end of this webinar. With us today, we have Eric from the Ipsos team and Jean from Living Beyond Breast Cancer, who will be presenting and discussing these highlights.
Hello, everybody. Eric Blouin from Ipsos. I'm an SVP focused in oncology. I've had 30 years of experience in the pharmaceutical industry. And great to be here to bring these results to you today.
Thank you, Eric. And I'm Jean Sachs. I'm the CEO of Living Beyond Breast Cancer. We are a national nonprofit, and our mission is to connect people impacted by breast cancer with trusted information and a community of support. So I think as you listen to the results of this survey, you'll learn why we were involved, because we're really focused on improving quality of life for those impacted by breast cancer, and definitely having less time in the doctor's office is a benefit, and treatments that are not as painful. So anyway, I'm excited to listen.
So Matt, why don't you take us to slide 3? And we'll talk a little bit about the objectives of this research. So overall, we wanted to look and understand the unmet needs of patients living with ER-positive, HER2-negative MBC. Specifically, we focused on 2 topics. We wanted to get in depth on the time that they spent attending appointments with their oncologist for treatment and assessment, as well as explore patient preferences for oral medication versus IM injections, and the benefits and drawbacks of each. So before we get into the results, I'll give you a bit of information on our methodology and as well the demographics of our respondents. So this was a study conducted amongst 100 women with ER-positive, HER2-negative metastatic breast cancer. We fielded a 20-minute self-administered online survey with them. And this was conducted in 2023, between August 23rd and October 18th. Our screening criteria were based on age, 35 to 75 years. Their primary diagnosis needed to be advanced or metastatic stage 4 breast cancer. They needed to be under active care by an oncologist to treat their breast cancer. And as mentioned, they needed to be confirmed ER-positive and HER2-negative. Because we wanted a homogeneous treatment experience, we also had a criteria to ensure that they had not taken fulvestrant as part of their treatment journey. In terms of demographics, we did have a representation across ethnicities. Looking at the US Census, we may be a little bit represented by the white population by about 10%, if you look at general population. In terms of age, about 50% of our audience was under 50. And a little bit over 50% was over the age of 50. Interestingly, in terms of employment status, almost 40% of our audience were either currently working on a full or part-time basis. And another 40% or so either were retired or chose not to work. Over 20% rather, There were 40% that claimed that they were unable to work or on disability likely because of their diagnosis. We had good representation across the United States, with perhaps a little bit less of an input from the West, a little bit more from the Midwest compared to the general population. But overall, given our sample size, these are within acceptable boundaries. All right, let's talk about our survey findings. So overall, we found that on average, it takes a typical MBC patient about 2.5 hours to attend their appointments with their oncologists. And that's time that includes what they spend scheduling it and making accommodations to attend their appointment, the travel time to the office and back, time waiting in the office, and the time that they actually spend speaking to their oncologist, to nurses or other healthcare providers, as well as office staff. So I found that to be quite stunning for the average patient to be spending this amount of time for a typical appointment. On average, they're seeing their oncologist every 6 weeks. And typically, it was a distance of about 25 miles to their oncologist's office, which aligns with the 35 or so minutes that was estimated as being spent actually traveling to and from the oncologists. So next, we wanted to assess a little bit more about their experience of scheduling these visits and attending these visits. 35% of our audience said that they needed to take paid or unpaid time off as part of their treatment. As well, they needed to find friends or loved ones to accompany them, often needed to rearrange their personal schedules, or even cancel family activities as a result of needing to visit the oncologist for treatment and follow-up. Moving on to treatment, when asked to assess the top qualities of breast cancer medications in general, from a list of possible topics or qualities we gave them, most of them chose side effects, as well as the overall impact on their quality of life as being key features that they considered as patients. Now, this was almost 80% of our audience, so it was quite interesting to see that it was so much weighted toward those qualities rather than efficacy. Interestingly, the number 3 attribute that was chosen was out-of-pocket cost. And it was a fair distance behind side effects and quality of life. So again, I thought that was very interesting because we hear so much about the cost of medications, the out-of-pocket expense, financial toxicity, but really at the forefront of our respondents' mind was side effects and quality of life. When looking at specific modalities or the mode of administrations of medications, again, providing them with attitudinal statements to see whether they agreed or disagreed with these. In general, they saw oral medications as offering convenience, empowerment, meaning they were personally involved in their cancer fight, as well as being cost effective with relative to any sort of travel related expenses, as well as time spent going to the oncologist's office to receive a treatment in on-site. And in fact, when we gave them a list of benefits that oral medications might offer, and this was a list of over 12 different possible benefits, we saw similar themes being echoed very strongly, that the freedom to take their medication in a convenient location, i.e. at home, at work, wherever it may be, as well as not having to travel to receive treatment, were the top two, clearly the top two that were found to be benefits of oral medications from our survey. On the other hand, looking at drawbacks of intramuscular injections as a treatment mode of administration, while we recognize it is an important part of care plans, many of the patients surveyed saw a downside, again, showing them a list of possible drawbacks, and amongst these was the opportunity to choose as many or as few as they saw. We saw that there were some concerns around injection site soreness, some general anxiety over receiving intramuscular injections, as well as recognizing that the injection or the site of injection could be painful. And overall, a majority of patients did find that not having to experience pain and soreness related to an injection of an intramuscular treatment would be a benefit that an oral breast cancer treatment might offer when they were specifically probed about this. So we'll open it up to questions at this point. I think, Matt, you've been collecting some Q&A through the chat. Would you like to share a few questions with us?
Yes. Let's see. I guess one to start with is just from your guys' perspective, how are these findings, or how do these findings influence the way we think about patient-centered healthcare within oncology?
Jean, you want to go ahead?
Sure. I mean, I think it's, you know, again, we recognize that it's a small study, but I think it clearly shows that if we can keep particularly metastatic patients out of the doctor's office more often, and that they can get medication that is effective with manageable side effects, that can be taken orally, and this gives them more time to do what they want to do. The whole reason you're fighting metastatic breast cancer is to have more time with your loved ones, doing things you enjoy, more time back, less cost traveling to treatment. So I think in general, if cancer care can move more focused on what does the patient want and what's best for them, and I think part of that is keeping them out of the doctor's office.
And for me personally, I found the empowerment point of view very interesting. The fact that taking an oral medication empowers the patient, that they are part of the fight, they are in the fight, they are doing something active. And, you know, as we know, that is a huge part of outcomes, is also the psychological aspects of patients with regards to their disease, whether it be cancer or any other type of medical condition.
Yeah, and I think we do have to acknowledge that compliance can be an issue with oral medications, and it is harder for the healthcare team to track. So we do have to pay attention to that too. And I think AI can help with that. I think there's a lot of ways we can encourage that, but we don't want to dismiss the fact that that is something that can be concerning. And we've seen that in early stage breast cancer with aromatase inhibitors and tamoxifen, and just compliance on that end.
One more. What what steps can HCPs take to empower or support patients to make more informed decisions about their treatment options?
So the question is healthcare providers, what steps can they take?
Right.
I mean, we just always encourage, shared decision-making, having really open conversations with patients about their options, if there are options, having healthcare providers really get to know their patients. Do they have young kids? Are they caring for an elderly parent? Are they working full-time? All these things impact, what might be best for them as they take treatment. So not assuming it's like one size fits all. So I think really, we always say that relationship with your medical oncologist is so important, that you can be open and honest and that they really listen to what's going on in your life.
Yeah, and I think part of it too is being able to provide patients with reliable and credible information sources. I think, as part of what we saw with empowerment is that patients want to, do their own research. And it can be pretty daunting if you go online and you don't necessarily have, the knowledge as to what is credible and what is not credible as a source. So that can be something that can be done to, help patients obtain the right information so that they can make the right decision for their own personal circumstances.
One quick question that I can address is there will be a recording of this webinar with the slide deck uploaded to the Ipsos website after the fact. One other question is, I guess, in what ways do these results contribute to our current understanding of patient preferences and how they impact treatment compliance, particularly since compliance is a concern with oral therapies?
Yeah, I think that's, I'm more familiar with compliance issues in the early stage setting. So I think with the metastatic setting, I'm less familiar, but I think it's both compliance and also feeling like maybe you're losing some connection and touch points with your healthcare team, which can be really valuable to patients as well as the healthcare provider. So I think we need to better understand, sometimes going into the doctor's office can be comforting, touching base, talking to them, as well as compliance. But I'm less familiar with what is happening in the metastatic setting in that area.
Yeah, and with regards to compliance, I think one of the benefits of the digital age we're in now is that everybody has, or most everyone has, a smartphone, which there are a number of apps that can be used as reminders with regards to medication compliance. So certainly, again, maybe that's something that could be an area for HCPs to explore. Are there some apps that actually are, free to use and that are actually credible ways of helping patients with daily reminders or, whatever the frequency of administration may be?
Yeah, and I think with compliance, it's also, are patients taking this in the way they've been prescribed? So we do know that sometimes if finances is an issue, which it didn't seem to be with this sample, are they taking it every other day or skipping it because they can't pick it up? So I think that's the other thing. Are they taking it in the right cadence? Because we know these therapies work only if they're taken as prescribed.
Let's see. There's a couple of tactical questions that I'll point folks to the formal release of the results of the survey. That's also included on the Ipsos website. So questions about additional data and stats can be found there. Another question, it would seem patients should prefer oral medications. What seems to be a barrier to getting them to change from injection to pills?
Well, if you want to, from a purely clinical standpoint, I think part of it is, what is for that patient's clinical circumstances, what is the best course of action from a treatment landscape? So, oncologists obviously have not only education, training, as well as years of experience typically in treating metastatic breast cancer as well as other tumors. So at the end of the day, I think there is still a lot that is dependent on the clinical condition of the patient. And I don't think that's a barrier. I think that is the case of the specialist's judgment that this is the best course of action for that patient. That is best treatment for that patient, regardless of the mode of action. So certainly, I think we can't disregard that. From specific or from true barriers, I would think that most likely, as we saw, not necessarily in this survey did we see out-of-pocket costs being an issue, but that is certainly something that underinsured or not, patients that are not insured might face because of the cost of copays or even the full cost of the medication that they may have to pay out of pocket.
Yeah, and I think as more oral therapies become approved and get on the market, that is sometimes slow to change, right? At healthcare, particularly, doctors want their patients to do well. So I think it's also just catching up with what's available. And that's why I think doctors or the healthcare team really need to know their patients and know what is going to be best for them in their specific, where they are in their stage of life. But I do hope lots of things become more available by not going to the doctor's office. And you're right, we have the technology now to do a lot more of that.
And there may be, patient preference as well. Some patients, as you noted, Jean, want to go in and see their care team regularly. They want to perhaps, see other patients in the waiting rooms that they know that are on the same frequency of visits, and that's part of their fight, and that's part of their support network. So certainly, I think those are all factors that I wouldn't necessarily call barriers, but preferences for one treatment choice versus another.
Yeah.
One more, or a few more we could do with the time, just scrolling. So going back to the time burden, that 2.5-hour commitment is relatively high. I guess, Jean, do you have a point of view on what might be, or what you've heard might be a reasonable commitment or expectation?
That is a good question, right? I mean, I think I was sort of thinking, wow, 2.5 hours if you're driving 25 minutes, maybe that's not so bad. I mean, I think when you have an illness and when you have to go to the doctor, I think time disappears, right? You never know how long you're going to wait. You never know when there's an emergency and your appointment might get shifted, like so many unexpected things. You hit a traffic jam. So I don't know if I have the ideal time. I think it's giving patients days back would be great. A day where they don't have to go, where they can get their treatment, but they don't have to go to the doctor's office. Because I think once you go, it's just like traveling. You just never know. Is your plane going to be on time or not? You just have to kind of go and accept whatever's going to happen. And I think it's a lot of that way when you're going to a doctor's office. So I think anything we can do to just really save those chunks of time and the number of days that they have to dedicate to getting their treatment is beneficial.
And while we didn't explore this fully in the presentation today or in the research, as we had a sizable proportion of our patients that were in their 40s, you can imagine that some of them, in addition to being employed, have to balance childcare. That, you know, they are mothers, and all of a sudden now you're juggling childcare, employment, as well as a 2 or 3 hour commitment to go see your doctor for your treatment of a serious disease. So even if you are, you know, if we magically could reduce that down to 1 hour, which sounds fine, right? But, you know, that is still 1 hour in terms of juggling a lot of different balls.
Yeah, we all want a clear schedule, right? We all want a day where we don't have to go anywhere.
And a few questions about this. It's hard to extrapolate from this data from the N sizes, but from your guys' perspective, would there be any variation by time commitment by the socioeconomic status of patients?
Yeah, that definitely wasn't explored, but certainly well, a couple of things. I mean, we do know patients that live in more remote areas often have to travel 2.5 hours or more for treatment. I mean, you know, as compared to people in cities or suburban areas. But if public transportation can be great if it works and it goes exactly where you need. But yeah, I think that, and you know, transportation's expensive. Everything's expensive these days. So I think it always takes a toll on those that don't have additional resources.
Yeah. And I think site of care is the other challenge, you know, with regards to transportation. So you may live, I live in New York City. You may live, you know, in New York City as well, and be 10 miles away from your oncologist. But if you are either driving or choosing public transportation, you know, that 10-mile might take you an hour to travel. Between traffic, delays on subway or bus, parking is going to be obviously an expensive proposition, tolls. So I think it varies a lot depending on a lot of different factors, and you know, location of the practice, where they're seeking care, as well as where they live, is probably more of a factor than necessarily ethnicity. All right, Matt, I think we are at time. I want to thank everyone for joining us today. As Matt mentioned, the full results will be available on the Ipsos website, as well as a recording of this webinar.
Great. Thank you.
Thanks, everyone. Thanks, Jean. Thanks, Eric.